Hello, welcome to the past test MRCPCH Part 1 online lectures. This is the second lecture in neurology. I am Dr. Archana Desurkar, consultant pediatric neurologist based in London. In this lecture, we are going to see some questions related to peripheral nervous system, neurometabolic disorders, and some miscellaneous. Let's define some learning objectives. I would like you to familiarize with some common neuromuscular problems in general pediatric practice. Also appreciate common neurometabolic disorders from pediatric perspective and touch upon some other miscellaneous neurological problems that may often present to pediatrician. Okay, let's kick off with an extended matching question. We are looking at the cause of weakness in the given scenario. The options are 1. Duchenne muscular dystrophy, B. Baker's muscular dystrophy, C. Wernicke-Hoffmann disease, D. Acute transverse myelitis, E. Guillain-Barré syndrome, and F. Hereditary sensory motor neuropathy. Okay, the first scenario is a 14-year-old boy, Charlie. He presents with inability to pass urine since this morning. He has had a diarrheal illness whilst he was holidaying in Scotland 5 days ago. He also has a backache and heaviness in his legs, and he thinks this is because of the long car journey from Scotland to London. Over the course of the day, he has become unable to weight bear and walk. He has no difficulty in moving his arms. Clinically, he is apyrexial, his blood pressure is normal. He has bilateral leg weakness across all muscles and also has urinary retention with palpable bladder. He also has some sensory loss in his leg to pain and temperature, and deep tendon reflexes are absent. This is clearly an acute presentation of weakness confined to lower limbs. So the differential is essentially going to be between acute transverse myelitis and Guillain-Barré syndrome, as both these present acutely. The important differentiating point here is lower limb involvement and in particular bladder dysfunction with urinary retention, and this indicates a spinal cord involvement rather than peripheral nerve involvement as in Guillain-Barré syndrome. So it is obvious that the diagnosis here is acute transverse myelitis. Acute myelopathy or acute spinal cord dysfunction can arise because of number of etiologies. This can be infectious or non-infectious. And again, going through a surgical sieve pattern of formulating a differential diagnosis, this can be trauma, infection as in spinal epidural abscess, vascular problems as in cavernoma, anterior spinal artery syndrome, autoimmune disorders or post-infectious disorders, similarly para-infectious disorders, post-vaccinal dysfunction, which is often mediated through autoimmune mechanisms, metastatic disorders, which thankfully are rare in pediatric practice, and so are the paraneoplastic manifestations. Acute transverse myelitis is manifested by sudden onset of progressive lower limb weakness, associated bladder and bowel dysfunction, and sensory impairment as well as backache. The backache and systemic symptoms may be predominant in spinal epidural abscess. There is affection of bilateral ascending as well as descending tracts, and I have put the section of the spinal cord with various tracts in the next slide. And because of the sensory and motor impairment below the level of the lesion, there is a specific identifiable level on clinical examination. The weakness is initially flaccid and associated with hyporeflexia because of spinal shock. The pyramidal tract signs will occur only gradually. The involvement can be patchy, particularly in the sensory impairment, and pain and temperature fibers are affected first, while the posterior column sensations, as in vibration and joint position, they are relatively spared. The evolution of the disease can be quite rapid over a few hours, as in Charlie, or can be protracted over a period of several weeks. If the cervical spinal cord is involved with transverse myelitis, respiratory compromise may occur. Preceding viral infection is common, as in Charlie's gastroenteritis, and the pathogenesis is thought to be autoimmune with the molecular mimicry mechanism. The spinal cord magnetic resonance imaging demonstrates contrast enhancement, edema of the spinal cord, and patchy areas of demyelination. The lumbar puncture may show some raised proteins and cells on analysis. As the mechanism is thought to be immunologically mediated, the treatment is by immunomodulation, and one would give a course of methylprednisolone. It is important to remember that acute transverse myelitis, if associated with optic neuritis, may indeed be the first manifestation of chronic demyelinating illness, and this is called neuromyelitis optica or Davick's disease, and this is associated with aquaporin A mutation. The prognosis of acute transverse myelitis in pediatric practice is slightly better than adult practice. About a third of children will make more or less full recovery, while a third will make a substantial recovery but may have some residual mild weakness or sensory impairment or some bladder dysfunction, while a third will not make very much or no recovery at all. But in general, 2/3 of children will recover substantially from the neurological deficit over a period of several weeks. The next EMQ is 3-year-old Callum. He is brought to the outpatients as a nursery feels that he is lagging in some motor skills like jumping and has a rather awkward gait when compared to other children at the nursery. His mother says that he was a little bit late in walking and walked only about 2.5 years of age, and he is a very poor runner. Clinically, you notice that he has a lordotic back. He appears to waddle while walking and is unable to run. He also seems to have difficulty standing on one leg, which you would expect for a 3-year-old child, and he shows pelvic tilt, that is Trendelenburg sign. He is having to climb on his knees when getting off the floor, and this is an indication of positive Gowers sign. So, the most likely cause of his weakness is. This is clearly a chronic condition. There are signs of proximal muscle dysfunction and in particular pelvic girdle weakness, as in waddling gait and inability to stand on one leg, as well as positive Trendelenburg. The Gowers positive again indicates proximal muscle weakness. There is also an evidence of delayed gross motor milestones, as in walking or climbing up the stairs that you would expect for a 3-year-old child. So the diagnosis here is going to rest between Duchenne muscular dystrophy or Baker's muscular dystrophy or hereditary sensory motor neuropathy. Given the proximal muscle weakness in a boy, either the Duchenne's or Baker muscular dystrophy are more promising diagnoses. And looking at the age of presentation, Duchenne muscular dystrophy fits the bill very nicely. And hence the answer is A. Duchenne's muscular dystrophy is the commonest genetic muscular dystrophy. It is quite common, 1 in 4,000 boys. As you all know, this is an X-linked recessive disorder, and hence asking the affection of male members of the family from mother's side, as in maternal uncle or maternal grandfather. However, about a third of the Duchenne's muscular dystrophy are new mutations, and mothers will not be carriers. The gene involved is dystrophin, and is dystrophin gene deletion diagnosed on the genetic testing. It is located on the short arm of X chromosome. It is typically characterized by progressive proximal muscle weakness, and as I already alluded to, this gives rise to Gowers sign, lordosis, and waddling gait. The motor skills are delayed, and these boys are never able to hop or run. They can also develop contractures and may develop toe walking at the presentation. They can also have associated speech delay, and calf muscle pseudohypertrophy. The creatine kinase tends to be very high as this is a dystrophic muscle condition and has ongoing degeneration and some regeneration as well as fibrosis of the muscle fibers. This is a progressive disorder, and the progressive weakness leads to loss of ambulation by mid-childhood. The life expectancy is limited, and cardiomyopathy and nocturnal hypoventilation may set in as the time goes by. However, over the period of years, there are a number of advances that have happened in the management of Duchenne muscular dystrophy, which has improved the survival, and now the typical life expectancy may be up to early 30s, while in the past it was in adolescence and certainly before 20 years of age, the boy would die. One treatment aspect is a treatment course with steroids, as the degenerating muscle fibers are thought to be inciting an inflammatory reaction. Steroids are aimed at dampening down this inflammation, and one tends to give cyclical steroids as in 10 days on and 10 days off, and this certainly has proven to be beneficial in prolonging the ambulation of the children. Better management and better investigations for cardiomyopathy as well as nocturnal hypoventilation have also improved the survival, and regular respiratory assessments for assessment of nocturnal hypoventilation and institution of nocturnal BiPAP as well as ACE inhibitors to manage cardiomyopathy have been important aspects of the management as well. Final scenario in these EMQs relates to 9-year-old Faye. She has always had very poor running skills and slightly unusual shape of her feet, very similar to her father and aunt. Otherwise, she is healthy, quite active, and quite agile. You find her to have rather thin calves, high arched feet, mild hypotonia, and her deep tendon reflexes are rather difficult to elicit, but you are able to get them symmetrically. So, the most likely diagnosis in Faye is. Now, in Faye's case, it is obvious that this is something probably familial because she has got unusual feet like her father and aunt. There's also a suggestion of peripheral weakness because of the thin calf muscles and high arch feet, that is pes cavus. Pes cavus is because of weakness of the intrinsic muscles of feet. She also has signs of peripheral neurological dysfunction in the form of hypotonia and hypoactive tendon reflexes. With these features, it is possible to localize her lesion to peripheral nerves, and hence hereditary sensory motor neuropathy or Charcot-Marie-Tooth disease is the explanation. This is the commonest inherited demyelinating peripheral neuropathy. This is autosomal dominant, and that would explain Faye's dad and paternal aunt to be affected. There is a significant intrafamilial variation in the presentation as well as progression of this disease. More often than not, it tends to have onset in mid to late childhood, and the symmetrical distal muscle weakness is only slowly progressive over a period of several years and decades. There is also a sensory involvement, and one sees glove and stocking type of sensory loss, which is typical of peripheral nerve affection. And the reflexes initially may be difficult to elicit as in Faye, but eventually areflexia will develop. These people can also develop contractures. The diagnosis is based on genetic testing, and 17p duplication of peripheral myelin protein or 17p duplication is the mutation to look for. The nerve conduction velocities will give a clue towards demyelinating neuropathy because the motor conduction velocity will be severely reduced, indicative of demyelination. Next question is a true or false MCQ. Hypotonia is typical in the following disorders. 1. Athetoid cerebral palsy. 2. Pompe's disease. 3. Neurofibromatosis. 4. Myotonic dystrophy. 5. Angelman syndrome. Let's review the differential diagnosis of hypotonia or floppiness. Broadly, floppiness can be associated with weakness or without weakness. And in infants and young children, weakness would be indicated by lack of anti-gravity spontaneous muscle movement. This would indicate involvement of the peripheral nervous system or paralytic floppiness. And going through again the pathway of lower motor neuron, start at the anterior horn cell, so spinal muscular atrophy type 1 or Werdnig-Hoffmann disease, going down to muscles, congenital myasthenia gravis or neonatal myasthenia gravis. In neonatal myasthenia gravis, about 12% of infants born to mothers with myasthenia gravis manifest this, and they can have transient feeding difficulties as well as respiratory distress. While in congenital myasthenia gravis, mother is not affected, and this is an autosomal recessive rare disorder. Neonatal myotonic dystrophy can also present with floppiness and feeding difficulties and prolonged dependency on the ventilator. Congenital muscular dystrophy and other inherited myopathies, particularly the severe forms of these with neonatal presentations, can give rise to a floppy baby. While the floppiness without weakness, where there is spontaneous anti-gravity muscle movement, is because of the central causes, metabolic causes, and some syndromes. The central causes, as in hypoxic ischemic encephalopathy, it can also be an indication of evolving cerebral palsy, and diplegias as well as four limb motor disorders go through a phase of hypotonia early on, and the spasticity sets in only later, about 9 months to 2 years of age. Metabolic causes, as in glycogen storage disease or Pompe's disease or congenital lactic acidosis, can have associated floppiness. Syndromic disorders, as in Down syndrome, Prader-Willi syndrome, would be associated with floppiness. And systemic diseases, as in hypothyroidism or chronic disease because of any underlying etiology, would also be associated with floppiness. So reflecting back on the question, number 2, that is Pompe's disease, and number 4, myotonic dystrophy, are associated with hypotonia, while the remainder do not have to have hypotonia. Angelman syndrome, as you know, is a 15p deletion of the maternal chromosome 15p or uniparental disomy. These children typically present with significant developmental delay and are also called as happy puppets. They can have epilepsy of early onset and they never develop speech. Myotonic dystrophy is autosomal dominant but mainly inherited from maternal side, and this is one of the disorders where there is genetic imprinting. The neonates present with hypotonia, feeding difficulties, respiratory impairment, requirement for long-term ventilation. However, they are able to come off the ventilator eventually and the feeding difficulty improves. However, the facial muscle weakness, learning difficulties, and distal muscle weakness is apparent as the time goes by. There is also a propensity to develop early cataracts, early temporal balding, and testicular atrophy. Cardiomyopathy is the life-limiting complication in myotonic dystrophy, and the diagnosis is by a genetic testing with CTG repeat sequences. This best of 5 is an image question. So look at this picture. The patient is trying to look to the right when this picture was taken. So what is the likely diagnosis? 1. Internuclear ophthalmoplegia. 2. Left fourth cranial nerve palsy. 3. Left sixth cranial nerve palsy. 4. Right fourth cranial nerve palsy. And 5. Right sixth cranial nerve palsy. Now we know that this patient was trying to look to the right, and we see the adduction of the left eye, while the right eye has not moved to the right or abducted. And this is consistent with right sixth cranial nerve palsy or abducens nerve palsy. It is important to remember which of the oculomotor nerves control which muscles. The third nerve or oculomotor nerve, if it is paralyzed, one gets ptosis, divergent squint, and pupillary dilatation. It supplies medial rectus, which pulls the eye in, superior rectus, which is elevating the eye best in abducted position, inferior rectus, which is descending the eyeball, especially while in the adducted position, and inferior oblique, which puts the eye out and up, while the fourth or trochlear nerve supplies the superior oblique muscle, which is responsible for looking in and down, as in descending the stairs, while the sixth nerve or lateral rectus is just abduction of the eye, and if this is paralyzed, then one gets convergent squint. So just remembering the distribution of the muscles and the nerves, one should be able to work out these sorts of questions. Next, MCQ. For a 7-year-old girl presenting with history of headaches over the last 2 months, A. Refractive errors are the commonest cause and hence referral to optometrist is required. B. Normal neurological examination virtually excludes the possibility of a brain tumor. C. Episodic nature and family history may suggest migraine. D. Females are more likely to have migraine at this age. And E. 1 in 6 children report headaches at this age. This is a question where some background knowledge and differential diagnosis of chronic headaches is required. After the age of 5 years, the stress headaches or tension headaches are the commonest causes for the headaches. And headaches are quite common, so 1 in 6 children having headaches at this age is true. Migraines can occur at all ages, and at 5 years of age, about 1.5% of children may experience migraines, while by 15 years of age, 5% of them. And pre-pubertally, boys tend to outnumber girls with migraines, while at the adolescence or about 15 years, the girls are more affected than boys. And in about 90% of children with migraine, there is family history of migraine. The migraines can be classic migraines with defined aura and hemicranial headaches. They can be common migraines without any definite aura, and the headache tends to be rather diffuse, and they tend to be associated with nausea, vomiting, and a feeling generally unwell. There's a category of cluster headaches where there is recurrent orbital pain with some autonomic manifestations like lacrimation, nasal stuffiness, conjunctival congestion. And these are very quick, last less than an hour or so, often in the middle of night. And the final category of complicated migraines and other equivalents, as in cyclical vomiting syndrome or ophthalmoplegic migraines or hemiplegic migraines. So a paroxysmal nature and family history may indeed suggest migraines. Brain tumors do give rise to headaches because of raised intracranial pressure. However, no single neurological manifestations will exclude them clinically. And if the index of suspicion is high, one may need to exclude this by appropriate imaging. Over the 1 year of age, posterior fossa tumors are the commonest ones, and they may not cause headaches until late in the illness. And often the raised intracranial pressure is because of associated hydrocephalus as that evolves over time, and the focal signs may be quite late. Eye strain does cause headaches, but it is not as common actually. So it certainly is not the commonest cause to warrant an optometric referral straight away. So the answers are: first is false, second is false, third is true, fourth is false, and the fifth option is true. It is important to remember to check the vision, visual fields, and signs of raised intracranial pressure by appropriate fundoscopy and blood pressure measurement at initial evaluation of any headaches. Another MCQ: following can indicate neurometabolic disease in a newborn or infant. 1. Stroke. 2. Hypotonia. 3. Acute ataxia. 4. Encephalopathy. 5. Dysmorphism and malformations. This question again depends on some basic factual understanding of neurometabolic disorders. The manifestations of these are really diverse, dependent on the underlying metabolic pathway involved as well as the age. Some of them present in a paroxysmal fashion with repeated episodes of encephalopathy or liver dysfunction, or even episodic or acute ataxias as in Hartnuff disease. These are often precipitated by a catabolic state as in infection, fever, trauma, surgery. In newborns or infants, the typical manifestations include dysmorphism or malformation, as in Zellweger syndrome or sometimes pyridoxine-dependent seizures. Microcephaly can occur in phenylketonuria. Seizures of early onset, hypotonia, liver dysfunction, acidosis, as in congenital lactic acidosis, suggestive of mitochondrial dysfunction. Encephalopathy and coma can occur. Sometimes hair and fat pad abnormalities can occur, particularly in glycosylation disorders. There can be some degree of lipodystrophy as well as inverted nipples and associated cerebellar atrophy. Some typical ophthalmological findings may again point towards a metabolic disease. While in older children, metabolic diseases may present with strokes, as in Fabry's disease,